Hello, everyone. Welcome to this free webinar presented by WePassed. I'm your moderator, Christina Ruiz. During this webinar, feel free to use the chat to ask your questions and discuss the topic. We will take time after the presentation during the Q&A to answer these. Throughout the webinar, we will stop the presentation to review. Look for the multiple choice review questions, which you will be able to answer in the polls section. Please go ahead and respond to these questions as they come up. You will have less than a minute to answer each one. This and other recorded webinars are available to WePass subscribers 24 hours a day, 7 days a week. Be sure to register through wepass.com to become a subscriber. Today's topic is titled Pediatric Radiation Oncology for the Medical Physicist, presented by Dr. Austin Fott, board-certified medical physicist and faculty member in the Department of Radiation Oncology at St. Jude Children's Research Hospital. Thank you for joining us, Dr. Fott. I'll turn it over to you.
Thank you, Christina. We'll go ahead and get started then. So just a couple of disclosures to get going. I do get a speaker honorarium from WePass, and my work is supported by ALSAC, which I'll talk a little bit about them here in the coming slides, but that's basically the charitable arm to St. Jude. So whenever you see those commercials and stuff looking for kind of fundraising for St. Jude, that's going through ALSAC, and they support the institution. In preparing this presentation, certainly wanted to make it broad and appeal to as many people as possible, but in particular wanted to focus on physicists preparing for the boards, because I know that WePassed is a resource that is especially valuable for them, and I used it extensively myself in preparing for both parts 2 and 3. So I guess to start out, what's different about treating children? There's a lot of things. Some of the obvious things, like they're smaller. Most of the time they are. Sometimes you'll get teenagers that are quite big. They have different types of disease. So a lot of the types of cases that you would see in adults just don't occur in children. One of the big things that we take into consideration is the quality of life and how long they're surviving after treatment, because when you're treating a 5 or a 10-year-old, you're looking to balance some of those late effects decades beyond treatment, where that might not be the same consideration that you have in an older population. But in the same thing, or in the same context, I would also say not much. The main goal is we still need to deliver safe and accurate radiation doses. And I put that in there not to kind of minimize the value that I hope to provide in this talk, but also as kind of a general piece of board prep advice, and just practice communicating kind of your core philosophy and principles. There's kind of a general approach to commissioning a new device. There's a general approach to making sure that you're delivering safe treatments. And even if you do come across a question that maybe you're not quite as familiar with, you can hopefully relate some of those principles that you're hopefully practicing and learning and reviewing in your preparation for the boards. So as a brief outline of my presentation, I'm going to give a little bit of an overview on St. Jude. That's partly because we operate quite differently beyond just the fact that we only treat children, and provide maybe a little bit of context where some of this presentation and my own experience is coming from, and recognizing that will likely be quite different from maybe the environment in which you might be treating children. Go over a little bit about how cancer itself is different in children. I think it's important to understand that and have an appreciation for it, because that greatly impacts the types of cases that you're seeing and how you approach treatment. As well as some of the unique considerations and techniques when working with kids. We'll review a few common cases that might be a little bit special to kids, and how we approach them at St. Jude, as well as some treatment technology in kids. So some of the state of the art and the new techniques that are either in the pipeline or have maybe even been around for a little while. Something like proton therapy comes to mind. I realize that's a pretty it's not nearly as widespread. A lot of you may not be coming from proton centers, but certainly in the context of pediatrics, it's very important. So I want to make sure and hit on a few of those things at the end without making it too specific to things of that nature. So St. Jude is located in Memphis, Tennessee. We've been open for about 60 years. We were founded by Danny Thomas, who's a pretty well-known actor back in the back in the 50s and 60s, and it's a pretty unique story about how he saw founding St. Jude to be kind of his calling, and the work that he put into that is probably deserving of its own lengthy presentation itself. So I definitely encourage you to look that up. It's pretty inspiring. We're focused on catastrophic diseases of children. That is primarily cancer. There's a few other things that we do have clinical and research interests in. Those largely don't apply to radiation oncology, but things like sickle cell disease and even influenza is considered a catastrophic disease for children. A significant portion of our operations are supported by ALSAC. That's the American Lebanese Syrian Associated Charities. That's the fundraising organization that Danny set up when he first decided to start St. Jude, and it continues to operate as a quite a force in terms of raising money for the institution, and provides us with quite a bit of resources. And that's important because in our kind of mission and the way the institution operates, we cover 100% of all costs associated with care of the patients. So that's not just paying for their IMRT and their exams by the physician. It's covering everything from their family traveling to Memphis. It's paying for their housing, their food. We truly do cover everything associated with their visit and care at St. Jude, including follow-up visits after treatment. Within the department, we treat about 350 patients a year. That's going to seem like a pretty small number, and it is compared to some larger academic centers, and especially when you look at the number of treatment rooms that we have. But as you'll see, and as we kind of cover going on, there's some workflow and complexities that are involved with treating a lot of kids that still keep us pretty busy despite what would be, by numbers, a smaller patient load. We have 5 physicians, 9 physicists, 3 dosimetrists, a couple of physics assistants, an engineer, and our own little IT informatics group, as well as a cadre of nurses and support staff. We have 2 LINAC vaults, 3 proton rooms, and our proton and photon clinics are kind of adjoined but separated by kind of half a level, and each of those has its own CT sim and MR simulator. We do have a brachytherapy suite with a fluoro machine in it, but we have increasingly not been using that as much since our proton center opened up. So I think kind of the main takeaway that I want you to get from pediatric oncology from a kind of a general perspective is that there's very different types of cancer. I've mentioned that already, and we'll talk a little more about that. The predisposition factors are also very different. A lot of the things that lead to adult cancers can be years or decades of exposure and behavioral habits that increase the risk for cancer, whereas in the case of children, those don't apply just because they're only a few years old in some cases. As well as treatments are weighed against long-term effects that are spanning decades. And that's really important as we look towards how we approach some of our treatments and consider some of our dosimetric constraints, and even consider things like imaging dose. We know that there's some risk associated with even things like that, and kind of imaging gently and being judicious in how we approach that. So pediatric cancers are much more rare than adult cancers. You can go to cancer.gov and look at some of the NCI statistics on this, but you can see really well just from this little kind of bar chart or histogram plot over here that the cases of people less than 20 years of age is only 1% of newly diagnosed cases, and that's from the SEER database. And you can even see, based on the incidence per 100,000, how much lower it is in patients ages 0 to 14 compared to ages 40 and up. So you're a lot less likely to see very many of these cases. And in fact, unless you're at a large center, it's very likely that you only see a few cases a year. Some of the predisposition factors can be quite different. We know in adults that smoking and tobacco use certainly increases your risk of developing cancer. Sun exposure, so if you're outside a lot, not using sunscreen, you can develop different melanoma skin cancers. other environmental causes, whether it be work environment, asbestos. A lot of times these are things that are building up over years or decades, when just because children are so young are unlikely to manifest as a factor in the cancers that they develop. With children, oftentimes what we see is their cancers are genetic in some nature, either some sort of mutation during development or in a not small percentage of cases, an inherited risk factor, about 10%. Environmental factors can be harder to pin down. We do know that ionizing radiation is some degree of risk, not just directly exposing them, but even in utero. So imaging dose to pregnant women can increase risks of leukemia. In terms of long-term considerations, quality of life is often stretching 10, 20, 30 plus years. And those are things that we are both tracking and evaluating and considering when we come up with treatment plans for patients. And that's manifested in certainly minimizing secondary cancer risk, unnecessary stray radiation dose, taking that into consideration. It's important in things like cognitive function, because these are oftentimes kids that are still developing, and things like low dose to the brain can impair their cognitive development, their social development. And so those are all things that need to be considered. Even motor control and functional rehabilitation, if you are irradiating developing muscles and joints. And oftentimes kids are still growing when they get treatment. So irradiating growth plates can affect their future growth and patterns. And we see that. And there's some really excellent data that St. Jude has published on some of their older CSI cases, where you can actually see the growth patterns of patients deviating from their peers that didn't get treatment, because they were irradiated all along the spine. I should also mention too, I put some credits down here where I got some of these images from. St. Jude has an awesome biomedical communications group that helps put together some of these infographics and some of these wonderful pictures. And a lot of those I pulled from them, including this graphic here, which mainly just wanted to show in general that as we've advanced the quality of care for pediatric oncology, patients are living longer and longer. And that's just emphasizing some of the long-term considerations we take into account for our patients. I'm actually going to step back one step here too, just because I think it's a really good story. It's actually a hallway along St. Jude where they have a series of pictures of current St. Jude employees that were treated as children. And these are 3 of them, just as an example. And you can see them holding pictures of themselves when they were at the time it was just St. Jude Hospital, and have now gone on to work for St. Jude. And there's probably a dozen of them. And it's always kind of cool to walk down that hallway and see just a glimpse of their story. So the different kinds of cases that we see in kids are often different too. So if we look at some of the common adult cancers that you might see more regular at chart rounds or go through endosimetry and you plan, you're looking at a lot of lung, breast, prostate, colorectal cases. None of those are very common in kids. What we're seeing a lot more of is leukemias. Those don't come through as much radiation oncology, but what's one of the more common cases in kids, different lymphomas, lots of CNS cases. I think about 60% of the patients we treat are CNS cases. There's a few other solid tumor sarcoma related cases, some Wilms tumors that kind of pop up there as some of the more common diagnoses in children. So in preparation for this webinar, I went and I tried to pull all the cases that came through St. Jude in 2019 to get an idea of what some of the more common diagnoses were that we treated. I will add the qualifier to this that our census is impacted by a couple of things. Not all kids get radiation. The institution treats about 500 patients a year, and we see about 350 of those. So that's affected a little bit. Protocol enrollment also dictates the patients that we take. We're very aggressive in enrolling patients on protocols here and really trying to not just certainly deliver great care to these patients, but also follow them and try and better understand the treatment paradigms in pediatric oncology and be able to share that experience with others. So a good majority of our patients are enrolled in some sort of protocol, and depending on the protocols that are open and recruiting, that will also affect which patients we see. We had a total of 54 different diagnoses in 2019. You can see quite a few of these are CNS related: medulloblastoma, ependymoma, a couple of different gliomas, GBM, and then a few sarcomas and other things that we see come through as well. Okay, so I think we'll get to the first review question. I think Christina is going to open up a poll there on the right that you can respond to this and answer. So the question is, which of the following types of cancer is not common in pediatrics? CNS, lymphomas, lung, or sarcomas?
All right, great. Yes, this poll is up for those of you who would like to weigh in. It'll just be up for maybe another minute. So please go ahead and make sure to weigh in. And then after you have a chance to weigh in on this poll question, if you have any questions for the Q&A, you can ask them in the chat section, and we'll be making sure to go over those questions at the end here after the presentation. All right, we'll just give everyone another moment, and then we can go ahead and review the answer. I don't know, it looks like most people are getting the right answer on this one. I think we can go ahead and review it. Oh, Austin, I think we lost your sound.
Can you hear me now?
Yes.
There we go. Okay. Yes, so the correct answer is lung. Every once in a while we'll see something that is maybe near the lung or even in the lung, but those are not primary lung cancers. Okay, so moving on to maybe some unique considerations in terms of the actual treatment. One of them is patient compliance. So you're dealing with young kids that are understandably frightened and in some very kind of scary situations in life for them, and certainly you can't blame even adults for feeling that way. And so you have to take that into consideration in your overall approach to treatment. Procedures can last anywhere from 20 minutes to, we have some proton CSI cases that will go over an hour. And that's a lot to ask a kid to stay still for that long. And so it's good to have a plan in place of how you can evaluate if the child is capable of that and how to hopefully work with them to ensure that they're compliant. A lot of times we have to use anesthesia in young children just because they can't tolerate treatment times. And that presents its own challenges related to workflow, even MPO, because they can't eat anything prior to going under anesthesia. And it's not unusual for a patient to show up and you ask them if they've had anything to eat, and they haven't, and that means they have to wait at least another 8 hours before they can go under anesthesia and get their treatment. And so there can be challenges associated with that. Child life specialists are just a godsend. They're wonderful. We have a fantastic team here. We have a couple that are associated with radiation oncology specifically, but overall they are working with children to help them cope, to understand the process and just kind of be a resource for them. We do lots of practice treatments with kids, trying to evaluate if they're ready to go through treatment awake. If they aren't, trying to get them ready so that we can take them off of anesthesia. You certainly want to minimize anesthesia use for their own health where possible. So we've got a great team working together for that. And we also have 2 new additions to the child life team. This is Huckleberry and Puggle, 2 therapy dogs that joined the St. Jude staff just a little less than a year ago, to quite a bit of fanfare. I think they're a hit around the institution, certainly among the kids and also the employees. So just some other anesthesia considerations. One thing that we encounter a lot is access to airways. So if we're dealing with a lot of CNS cases where you've got a mask on a patient for immobilization, the typical head position that you might want to put a patient in can sometimes be challenging for anesthesia to get access to an airway. So you may need to tilt the chin up a little bit more than what you're used to, and it's important to have kind of that good relationship with the anesthesia team and trying to kind of work and find a way that you can hopefully get a mask that fits well, that immobilizes the patient so you can treat accurately, but also allows them to safely do their jobs as well. Cameras for monitoring anesthesia equipment in a room, something important to consider if you're commissioning a new machine or you think that you would like to start treating kids, as anesthesia needs to be able to see those monitors from outside the room. Also, plans for working off sedation. Oftentimes what we see is when a child is coming off of anesthesia, so we do this a lot of times in like our CSI cases, look at a focal boost after they have a few weeks of CSI. We'll oftentimes need to do a new CT just because maybe that same airway position that we needed for anesthesia is oftentimes uncomfortable for them while they're awake. Maybe it's because they're no longer relaxed in the same way. So just kind of being aware of some of those positioning challenges as well. And also give a little diagram of our proton center here. And in blue is the post-anesthesia recovery area, and in green are the induction rooms. Now we have 3 of those and probably a bigger recovery room than what's needed in most departments, but certainly things to keep in mind of where you're going to kind of put the kids under and put them to sleep, and where are they going to be at when they recover, and just kind of general workflow and space issues that you might otherwise not consider. So imaging in pediatric RO, I mentioned anesthesia is regularly a consideration. You need to be able to provide space and equipment to CRNAs. A lot of times they have a bunch of stuff that's in there, and making sure that can be safely placed in the room and it's not getting in the way, and they can kind of do their job. A large portion of our cases are CNS cases. So you're probably going to want access to an MRI. Either we have certainly a departmental MRI, but you can also use institutional machines, whether it be in radiology or diagnostic imaging departments, or getting outside imaging so that you can accurately identify those targets. As well as sometimes you're going to have smaller structures, and those might require smaller slice thickness. And kind of keeping that in mind while also realizing that oftentimes means more imaging dose. So kind of balancing that trade-off and understanding what kind of comes with that. As well as sometimes traditional immobilization might be too large. So in some cases we have pediatric specific masks or smaller size kind of body fix bags, just because for a 5-year-old that might just be too much excess material and not fit quite as well. And some of this also carries over to on-treatment imaging, and kind of balancing some of your different imaging modalities that you might use for patient positioning. This gets to be a tricky thing because this patient is sick. You want to make sure that you treat them as accurately as possible. A lot of times we're trying to get our margins down as low as possible so that we are sparing some of the nearby healthy tissue as much as possible. And in order to do that safely and accurately requires a lot of imaging. And so it's definitely a trade-off that needs to be considered in terms of use of planar imaging versus 3D cone beam CT acquisitions, and considering the protocols that you use for those imaging devices in order to hopefully minimize dose without sacrificing your accuracy. As well as it's not just patient setup in IGRT, but just being aware that some disease sites are prone to anatomical changes. So we do see some cases where there's quite a bit of tumor shrinkage. That's especially important in protons, and kind of being aware of how some of the nearby anatomy might change. Weight loss, a lot of times we see with their chemo regimen, or if they're on a steroid like prednisone at the beginning of treatment, as they come off of that, they might, lose weight. As a result, their immobilization devices don't quite fit as well. So kind of being aware of those and tracking your daily imaging and intervening as necessary to ensure that you can still set them up accurately. Chaho Waz, our kind of pediatric RO imaging expert, not just ours, but nationally, and he provided me some really great slides from a COG presentation that he gave at Astro that just shows some of the different preferences nationally among COG institutions. It's now this survey looking at what types of imaging techniques are used in patient setup. And you can see quite a bit of KV3D, so your cone beam CTs, as well as some 2D planar imaging in there. You do get see a little bit of a spike in the MV2D, so the port films for things like Wilms or things that might otherwise just be treated with an APPA and that be appropriate, as well as kind of a clustering of people that use mixed modality. Likewise, you can see for the frequency of imaging, it's another consideration to take. Overwhelmingly, this is daily acquisition of imaging. And in case you couldn't see as well, these colors represent different diagnoses, so they correspond as well to the disease site that we're treating. A few cases where you're doing weekly, again, those are largely those APPA cases, but overwhelmingly daily imaging. Motion management, I included this in here. Generally, we're pretty lucky that with smaller patients, you have smaller motion, and we don't see as many of the disease sites that you do in adults with some real large magnitude of motion. But it's definitely something to be aware of and to make sure that you're identifying that you're able to adequately handle that, be it just the use of an ITV or other strategies. If a patient is under anesthesia, your options are kind of limited. You can't do a breath hold. You can't, you don't have quite as much leeway in how you handle that, but thankfully they also tend to breathe a little bit shallower. So you see even less motion in those cases. So we'll talk a little bit about a few different treatment techniques and go over a couple of cases. Before I get to that, I'm again borrowing a slide from Chao Ho that looks at some of the different modalities that are used in treating pediatrics, and you can see it's definitely biased to some of these higher conformality treatments like IMRT and VMAT, and even increasingly the use of protons in a lot of these 30-40% of the people that are responding there. It's getting pretty high. And medulloblastoma is up there, a notable peak within protons. That's those patients are often getting CSI treatments. And I'll go over a little bit about proton CSIs at the end of this presentation, but you get some really great dose distributions for those cases. Some 3D cases, and again, those are those APPA cases, some of the whole brain or Wilms tumors that I alluded to during those imaging slides. So the first one we'll cover is a CSI treatment, craniospinal irradiation. I'm going to talk a little bit about this from a photon perspective, just because you're a lot more likely to get this on a board asking about photon CSI than you are proton. So in these cases, we're treating all of the CSF because it's unlikely that a patient's going to fit in a 40 centimeter field size. It's probably going to require multiple isocenters, even for a kid. So the way we break that down is we usually have 2 lateral cranial fields, treating the entirety of the brain and some of that upper spine area. And then usually 1 or 2 spine fields, we treat them. We have posterior spine fields, so the patient is supine. There are also some places that will treat these patients prone. So they will be, I guess, still a posterior field, but the patient will be flipped over. It's important to think about treatment geometries. Because you have multiple isocenters, you need to start considering how you're going to match at these isocenters. So typically what we'll do is we'll rotate the collimator, as you can see in that top cranial image, so that it will match the divergence of the upper spine field. And then we'll also need to take the divergence of that cranial field out through a couch kick in order to get a clean match there. We also typically change our junctions every 5 fractions, so about weekly. We'll move those up about 1 ml leave, just so that if we do have a little bit of more overlap, we aren't repeatedly under or overdosing the same area. So now our next question, how is the couch kicked for cranial fields of a CSI? It isn't kicked. It's kicked towards the gantry. It's kicked away from the gantry.
All right, great. This poll question is up. in our polls section, so be sure to go ahead and answer this question while you have the chance. And we have some questions already in the chat for the Q&A, which is great. Thank you so much for those of you who are engaging in the chat window. And I hope that those of you who haven't had a chance to ask a question make some time during this polls section to ask a question for the end of the Q&A section. And we're getting a wide variety of responses here.
Oh, almost evenly split.
All right, so we'll give everyone just another moment. Okay, I think we can go ahead and review the answer.
So this is maybe a little more of a part 2 question than a part 3, but it's definitely fair game as a follow-up should you be shown. Maybe some of the DRRs, like we looked at the last slide, an examiner might ask you to kind of step through the process or tell you you're walking into a treatment room on the first day. Do you expect to see the couch kicked, if at all, and in what direction? In fact, it goes towards the gantry. And it's important if you get something like this, it's hard for me to visualize something like that just when I'm seeing text on here. So talk your way through the question and explain your reasoning. I'm removing the divergence at the cranial spine field border. I like to use my fingers. I make kind of a peace sign, and that's the divergence of the beam. And I can kind of hold an index finger out to represent the couch, and how do I remove that divergence? And if you do that, you'll see you actually need to kick towards the gantry to kind of flatten out that inferior border. So another somewhat common case in pediatric cases is total body irradiation. Switch my view real quick. This is oftentimes preparing a patient for transplant. The goal here is to deliver a uniform dose to the entire body. The one exception being we'll usually shield the lungs just because you're more likely to see some toxicity there. And this presents some unique challenges, and you see a lot of different ways to approach this based on the clinic you work in and some of the constraints that you might have in your treatment room. A lot of times you'll see extended SSD, which is in fact what we do for the majority of our cases. Move the patient all the way to the far side of the room so that you can fit them in a single field. If the patient's small enough, you can sometimes just treat them on the floor. Another thing to be aware of is the dose rate of the patient. We try and keep ours around 8 centigrade a minute. I think 12 is about as high as you want to go. There can be some toxicities if you allow that to get too high. The treating an extended SSD will help you in that regard, but you're also probably going to need to dial back the dose rate of your machine some. So this is a little bit tough to see what's going on here. We have kind of an extended SSD setup in which we will position a patient on what is kind of like a rotisserie, and we'll lay them down in this machine. Will rotate 90 degrees so that we can still treat in kind of an APPA fashion, which helps us with our lung blocks, but still suspends them. And this had some historical context where it helped with some of our anesthesia cases, and they set that up. You'll oftentimes just see patients maybe decubitus on a gurney or a bed across the room, or even just laying down. And over here on the left is also the board that we'll sometimes treat real small patients on if we can fit them within the field just on the floor. You can also kind of see in the background is that that device that we'll lay patients on. In that case, it's not rotated, but they're basically just sandwiched between kind of 2 backlock bags to keep them in place, and put a little cartoon head there so you can kind of see where the person's at, but they're largely covered up in this image. Okay, so another board question here. You'll oftentimes get a picture and be asked to describe what's happening or what you see. So what is the device shown used for? It's a sneeze guard for patients with weakened immune systems. Filters out contaminant radiation, increases skin dose to the patient, where it acts as a visual for effective treatment field.
All right, great. This question is up, and I see some folks have already started to weigh in, which is good. You'll just have a minute here to answer this one. And then we do have a lot of questions in the chat, which is great. So be sure to stick around after the presentation to have those questions answered, or maybe, if you have a question, see if your question's already up there, or if not, you can go ahead and add it. And we'll be getting to that at the end of the presentation. All right, looks like a lot of folks have weighed in on this review question. I think we can go ahead and go over the answer.
Good. Yeah, it's a beam spoiler, so it's used to increase skin dose to the patient. So you want to get a uniform radiation, so you don't want that build up there. So by adding contaminant radiation, in this case, not filtering it out, you can increase the skin dose to the patient. Kind of the last photon specific case that I'll go over is TLI. You see a decent amount of these come in. It's another pre-transplant immunosuppressant that we deliver, and we're irradiating all the lymph nodes in this case. Typically, you'll see these as a BID treatment with a kind of a gentle fractionation or dose of about 150 centigrade. A lot of times what we'll do is we'll treat this for 4 fractions. We'll do kind of an afternoon treatment, 2 treatments the next day, and then a morning treatment. And that's preparing the patient for transplant. You can see the blocks drawn on this patient and the dose distribution that comes from that, as well as the different lymph nodes that you're catching in that field on the far left there. So quick turnaround here, another question. Why is there an unblocked area on the patient's left? This is likely to cover metastatic spread. The inferior of the heart needs to be covered to irradiate red blood cells. The spleen is included in TLI fields. And this is an error. It should have been caught by a physicist.
All right, great. So this question is up, our second to last question for this presentation. So make sure to go ahead and answer this poll question while you can. And also, the chat is available for any Q&A questions that you might have. All right, so it looks like folks are weighing in. We'll just give everyone just another second to answer this, and then we can go ahead and review. All right, why don't we go ahead and go over the answer here?
Yeah, awesome. So overwhelmingly, it's because the spleen is included in TLI fields. It's an important part of the lymphatic system that we want to make sure and hit in these treatments. I'll mention pediatric brachytherapy because this is done because you have some sarcomas that are well treated by interstitial HDR. We don't see a whole lot of these cases. A lot of times we send our sarcomas to protons. Every once in a while we'll get something that just isn't well suited for that. I think we've maybe only done a few cases in the last 2-3 years. This is, I think, our most recent case that we had recently, where a patient had sarcoma in the base of tongue, and in this case, with kind of the mandible and the air around the oral cavity, just doing protons was not a good option. So we actually came with 4 kind of catheters up through the bottom of the chin and got that there into the base of the tongue, and really got a pretty good treatment plan on that one. We'll get an occasional eye plaque as well. Again, those are pretty rare. So now is when I'm going to kind of jump to some of the other advanced technologies or some of the things that are developing or increasingly being used. Proton therapy being a big one. That was a huge undertaking by our institution. We opened our proton center about 4 years ago. It was in planning for quite some time, as you can see from this infographic. This bottom left image is the big pit in the ground during its development. St. Jude built a pretty big building with the basement of that being our proton center, and you can see inside one of the treatment rooms. I think that's 2 of our therapists setting a patient up. So proton therapy is important in pediatrics. There's some debate over the economic viability of protons, and for a while it was kind of controversial over, should we be building this many proton centers? Is it an unproven technology? It's expensive. But I think one area where a lot of people were especially kind of bullish on it or had hopes for it being especially useful were in kids. Just because you can get so much lower of integral doses when compared to VMAT and IMRT. And as we see, when you're balancing some of these late-term effects decades out, reducing that dose, it matters. And we hypothesize that, in fact, in protons, that we'll get a lot better of results accordingly. I don't want to make this a proton talk, but I think it's important to understand that there's kind of 2 primary means of delivering protons. Passive scattering and scanning beam. Increasingly, new systems are pencil beam scanning. What that is, it's basically a single pencil beam that's steered by a magnet, and you paint dose on the target. A a lot of the older systems, or the ones that were kind of coming out in the early 2000s, were passive scattering, in which you get a series of scattering foils that give you kind of a broad beam geometry that then needs to be collimated and shaped through apertures. So a couple of the cases that we'll hit on real quick here. Proton CSI has been a big undertaking for us. We saw that spike in the number of medulloblastomas that we're treating with protons, and that's because you can get some really great treatment plans on proton CSIs. And you can see how much of the body we're sparing from low doses compared to some of those typical photon CSI fields when looking at this patient. Typically, we'll treat with 4 fields. Again, this is going to be a little bit institution dependent on how they approach these cases. We have 2 kind of posterior lateral fields for the cranium. You can see that in kind of the axial slice here in the patient's head, where we'll come in from behind, and then 2 posterior fields that will treat the entirety of the spinal canal. Field matching is a little bit different in protons. In this case, we purposely apply a dose gradient. That way, if you think about, if you went straight from 100% dose down to 0 for each field, and you had a little bit of a gap in your fields weren't aligned perfectly, you might get 0 dose to an area, or if they did overlap, you might get 200% dose to that area. Whereas if you apply a dose gradient at that junction and you're off by a little bit, you're only actually changing your dose there by in some cases just a few percent. So it's an overall more robust means of setting up your treatment. Also consider where you place the ISOs. So depending on what your imaging setup is and what you can capture in a field, that's especially important. So typically what we'll do is we have to take into consideration that each jaw within our cone beam CT system can only open up as far as 14 centimeters. So that's a 28 centimeter kind of longitudinal field of view. And we want to make sure that we are not clipping the C-spine kind of neck area where you can get quite a bit of flexion, as well as the sacrum where the hips can be tilted a little bit, and those can affect the kind of pitch of your alignment. So you want to be sure that those are caught in the field of view. Sometimes you'll get patients that are so tall that it's impossible to get all of the treatment volume in that field of view. And so you might need to clip a little bit off. We'll usually skimp at the top of the brain there a little bit, because we're pretty confident that if we have the majority of the skull, that top part's going to be rigid and it should align. But you definitely don't want to miss out on some of those areas that have a high degree of flexion. You also want all those isocenters to be in the same plane. That way you can just move the patient longitudinally or move the couch as you transition from isocenter. Less likely that you have a mistake in setting the patient up, and as well as just making the workflow easier for the therapist. Okay, I think this is our last review question. When might vertebral bodies be evaluated for coverage in a CSI case? When metastatic disease is present, in prepubescent children, when adequate robustness isn't otherwise achievable, and only when a boost is not planned after systemic therapy.
All right, great. Yes, this question is up, and it is our last poll question. So make sure to weigh in on this one. We'll give everyone just a minute to answer it. And thank you again to everyone who asked questions in the Q&A. We have a very robust list of questions there, so we really appreciate that. So be sure to stick around after the presentation to have your question answered. All right, it looks like folks are answering this question, maybe just another few seconds, and then we can go over the answer. Okay. I think we can.
Yeah, this is really good. So I didn't actually address this in the presentation. It's a lot of times in prepubescent children, and the reasoning is, so if you have a dose gradient that's going through the vertebral bodies, we talked a little bit about radiation can affect growth patterns. So if you actually have a dose gradient there, what you can get is asymmetrical, atypical growth patterns in the actual vertebral bodies themselves. And so while you can't really do much about that in photons, just because you're dealing with exponential attenuation 1/r squared, in protons you actually modulate dose along that. So a lot of times in prepubescent children or children that are still growing, we'll actually try and cover with 60 to 80% of the prescription dose in that vertebral body and just give it a uniform dose so that we aren't affecting the actual growth patterns and potentially deforming their spine later on. I'll skip over this here real quick, but this is just showing the dose gradient at the junctions. So you can see these are two different fields, each with a dose gradient, and then when summed together at that junction, it's giving you a uniform dose. And you can kind of imagine if these fields with respect to each other were shifted a bit during setup, you would have minimal disturbance to the actual total dose compared to if you had a sharp gradient there. So lots of our cases are focal brain treatments. Usually these are just two beams, so it's a little different from IMRT or VMAT where you're trying to increase the number of beams to get a more conformal treatment. And you can do that to an extent with protons, but I think keep in mind that one of the advantages to protons is you can get lower integral dose. So if you're adding more beams, you start losing out on some of that advantage. And likewise, in choosing where your beams are coming from, kind of minimize the path length traverse. This is a pretty central tumor, so just having two lateral beams works here. But if it has some laterality, then you may not want to shoot all the way across the brain just to get to that far right or left side. So you might take a little more of a posterior approach. When possible, we try and avoid acute angles between beams. So this is a little controversial. Our idea is that it minimizes end of range uncertainties tied to high LAT. So the end of range RBE effect is an open question in protons, and it's of particular interest in children. And so this is just kind of one way of us hedging against some of that uncertainty. Usually when you have an acute angle, it's giving you a bit of a spike in LAT. You can imagine the end of range high LAT from one beam tends to be overlapping a little more with the other one. So when possible, we try and avoid that acute angle. Keeping in mind, again, we want to kind of minimize the path traversed by the beam. We do get some proton retreats. You can get some really great dose distributions with protons. You got to be really careful here, though, and make sure that you understand your robustness, not just in coverage, but also in sparing. So we'll get some patients that will come in and get basically brainstem sparing CSI. And you can see here where we're actually delivering a CSI and carving out an area of prior treatment where they might have gotten a focal boost and already have kind of more remembered dose, if you will, in that region. And because we're re-irradiating in that area, maybe especially sensitive, we'll actually kind of carve that dose out a little bit. We have an active retreat protocol open. So you want to be extra sure you take some time fusing your prior imaging and you understand where that prior treatment volume was when going through these cases. Another thing, not necessarily proton related, that we have installed a unit in our proton center is surface guided radiation therapy. So there's a number of different systems out there. This is really useful in terms of quick and accurate positioning of the patients. That may be extra helpful for kids. I think Children's Hospital of LA has a lot of experience doing this, and we talked to them quite a bit as we were getting our own SGRT program going. And Oscar Atesh is kind of the physicist that's been responsible for driving that. It's also great for intrafaction motion monitoring, making sure kind of kids stay still. It's important for us because we have a bit of a unique proton setup in our room, and there's a lot of different couch kicks and stuff that are going on, and making sure that we're maintaining that accurate treatment position is important. It also enables some motion management strategies related to breathing. Again, I mentioned some of the typical strategies like a breath hold or something may not be possible under anesthesia. So having some means of monitoring, in this case with an SGRT system is helpful. And that's something Oscar is also working on commissioning right now. And also reduced imaging dose. So if you can get a good setup with this, maybe it's possible to reduce the frequency of your imaging, or maybe you can transition away from some cone beam CT patients if you can, or certainly do them less often. So I think that's also kind of one of the hopes as we gain more experience with this system. You don't really need to study this too much, but this is just showing our SGRT setup at St. Jude. I mentioned we have kind of a unique setup in our proton room. So this is kind of an overview of that. And we actually, instead of the standard 3-camera setup, have 5 cameras so that we can cover a number of different imaging ISOs that are separate from the treatment ISO itself. And that helps us to ensure that as we move the patient from that imaging setup position, they're actually still in that same position that we image them to by the time they get to the treatment ISO center. We can beam on. This was really a pretty complicated setup, and Oscar did a good job working through that. So that concludes the presentation. So I'll close here and kind of open up for questions. I included a few pictures of Halloween. Trick or treat's a very big deal at St. Jude. It's probably the most popular holiday on campus, and certainly patients and staff buy into it. So wanted to include a couple of pictures that I picked out and thought were pretty cool.
Thank you so much for doing this presentation for us, Dr. Fott. So we're going to scroll down here to the bottom of the chat where we have our first question, and that is, do you do any brachytherapy for these kids?
Yeah, it's not common, and we've kind of preferentially shifted a lot of those patients over to protons compared to what you might have seen 5 to 10 years ago. I've been here for about 3 years, and I think I've only seen 2 or 3 cases. It's usually if it's in an area that's just tough to get. Maybe it has a lot of uncertainty associated with treating with external beam therapy, and we'll approach that with brachy, but it's not common for us. Maybe in other places you might see it more often.
Thank you for answering that question. Our next one here is, do you use COG point-based evaluation of TBI or volumetric constraints for lungs?
We just use a point dose evaluation. We don't do any kind of volumetric evaluation for that. It's a good question.
All right, great. Our next question here is, what type of tolerance table do you use, an EMAMI or Quantitech?
Yeah, so that's another good question. I mentioned earlier, we're very protocol driven. So oftentimes our patients are enrolled on a protocol either institutionally or through COG, and that is oftentimes driving our dose constraints. There are our own internal dose constraints set up for that. A lot of times that's getting published and that's informing other kind of pediatric standards of care, or it's based on the COG trial that they're enrolled in.
Okay, great. Thank you. Our next question is, what are some typical PTV margins you use for these cases?
So that's going to vary widely based on the case that you're doing. And it's also worth mentioning about, at this point, probably 2/3 to 3/4 of our patients are being treated on protons. And in protons, you're not looking at a PTV margin, you're starting to evaluate things like robustness. And in those cases, we're using 3%, 3 millimeters. For some of our other cases that are on photons, usually the reason they're on photons is because it's maybe a little more diffuse of a case, it's maybe a poor prognosis, or it's a more challenging case. So it's probably going to be biased towards a larger margin to begin with, because if we think we can treat them with really high precision and get that great dose fall off, they're going to go to protons at that point.
Great, thank you for answering that question. Our next question, do you find issues with contour changes due to anesthesia gas in the abdomen?
I don't know that I've seen any gas specifically related to anesthesia, and if I did, I don't know that I would be able to attribute that to anesthesia. We do see sometimes we'll get a bolus of fluids, and that will sometimes affect the bladder. So if you've got a sarcoma case kind of around the pelvis, it's important to keep that in mind, because sometimes you'll get pretty quick bladder filling, and you need to make sure that you're consistent in terms of how you're imaging the patient as well as how you're treating them. That's usually what we see, but not a whole lot related to gas changes.
Thank you for answering that question. Our next question here, do you evaluate the dose due to the daily imaging?
So it's a part of our QA procedure. So we're certainly going through and QAing our different dose techniques and the different types of imaging that we use. We don't track the daily dose in their treatment plan or their chart notes related imaging.
All right, great. Our next question here is, what technique are you using to plan the junction shifts?
So the junction shifts are done in photon CSIs. There's no junction shift in a proton CSI. Usually what we'll do is we'll just open up a single MLC at the border and close another one, so that we're kind of shifting one MLC at a time, and we'll do that on a weekly basis, kind of moving it on up the patient.
All right, thanks for answering that one. Our next question here is, what couch top for kids brain CSI case with proton therapy?
Yes, we actually have we kind of have our own custom setup that we machined in-house that the patient is actually affixed to. And let me see if I can go back and show you that slide there. So one thing I didn't hit on is, so the energy of the protons is going to affect its range, obviously. There's a minimum energy in most systems. And that means if you're trying to treat something that is within that kind of initial buildup area, if you will, you need to use something called a range shifter. So you basically just put a slab of plastic in the way, and that will pull the range back. It's about 4 centimeters that we use. So we just have this slab that we kind of milled out some holes that we can fix on the mask and such, and that's actually pulling that lowest energy Bragg peak back enough that we can cover dose there in the surface.
All right, thank you for answering that question. Our next question here, how do you handle retreatment in pediatric cases? MD preference or specific guidelines?
A little of both. So we have our own internal protocol that we're recruiting for at RER, TEP. Dr. Merchant has that open, and there's guidelines based on that, as well as kind of the physician's own kind of experience in handling that, depending on the disease site and what type of retreatment that we're getting.
Okay, thank you for answering that one. Our next question here, do you know the specific toxicity related to the dose rate for TBIs?
I did at one point, and I'm forgetting now. Sorry, I'll have to look that up because I remember specifically asking a physician about that, and I don't remember.
Okay, thanks. Our next question here is private, but I'll go ahead and read it out loud. Do you find that physicists are required to be at the units more frequently than in adult cases for patient treatments? Also, is there a need for more physicists to communicate with more with patient and parent?
Yeah, so that's I would say that that's probably affected as much just by how your department operates than it is pediatrics versus adults. I've kind of been at a number of different places that approach that differently. I'll occasionally go and talk to patients or families. It's not very common. UC San Diego has a really great program that they've been putting in place and trialing and also teaching other people about in terms of kind of physicist-patient interaction. I think it'd be really interesting to see that in the pediatric sphere, but not as much. We largely our child life specialists are handling that, and they've kind of got a pretty established relationship with the patient from when they're first admitted to the hospital and kind of brought in and kind of given the rundown of what's going to be happening. So by the time they even come to our department, they've probably got at least a week or two of a relationship built with that child life specialist. And we'll occasionally work with them to kind of address things, or maybe they want us to be there for a practice treatment to make sure that they're handling it all right. But, I wouldn't say it's affected us a ton.
Okay, thank you for answering that question. Our next one here, do you have any issues with temperature of the room when you use Surface Guide?
Not that I'm aware of. It's as a result of the Surface guidance. I don't know. It's a big room, so I would think it would have to. I'm not sure how that would happen, but I'm not aware of having issues related to that.
Okay, thanks. Our next question is, what's the minimal length to reduce the junction CSI effect of the two fields when using VMAT?
So I assume you're asking about is this referring to maybe a dose gradient in which you have two fields patched together? I'm not sure I fully understand. So in the case of our protons, we overlap those fields by about 7 centimeters. And we find that gives us, forgetting what the numbers come out to be, but we calculate it so that if we know that there's a certain millimeter offset that we're off by, it keeps the dose within a set tolerance. But I'm not as familiar with VMAT, 1, because I haven't used it, and 2, because I'm not sure I follow. But sorry.
Okay. That's all right. Thanks for answering anyway. Here's our next question. Is your TBI CT based?
It no longer is. We've kind of transitioned away from that. For a while, we were doing a CT to try and collect a number of different data points to try and better evaluate and make sure that we were in fact delivering the dose that we did. But we've transitioned to just taking a few separation measurements and doing a hand count based on that.
All right, great. Our next question here is, do you have special smaller dose grid considerations, patient-specific QA verification parameters?
I wouldn't really say we have special dose grid considerations. We usually try and keep it smaller. So we use Eclipse as our treatment planning system for protons, and the way their algorithm works, you're probably more limited by the algorithm in taking your dose constraint down, or your dose voxel size smaller. So I wouldn't really say we said anything special related to that.
All right, thanks for answering that one. Our next question here is, are your pediatric specific immobilization devices commercial products or devices that have been developed in-house?
It's a mix of the two. So we have an awesome engineer that is really resourceful and has kind of developed his own suite of products. This range shifter board for CSI cases being one of them. That kind of TBI setup that I showed being another. But we also go to some commercial products like things like masks and kind of the bags for body sites are commercial products.
Okay, thank you so much for answering that question. Our last question here. Do you need range shifter frequently for proton, and does it block or interfere your surface guide?
So we use range shifter fairly frequently. A lot of times if it's a CNS case that's kind of more central in the brain, then at that point it's deep enough you don't need a range shifter. So our minimum proton energy is about 69 MeV, which corresponds to about a 4 centimeter depth of the Bragg peak. So it's really anytime we're treating shallower than 4 centimeters is when we need the range shifter. It does not interfere with the surface guidance because the range shifter slides into the nozzle itself. So if you imagine kind of an accessory tray on a Linac, it's kind of similar for our proton machine. And in that case, it is not blocking the surface guidance camera, so it shouldn't have any effect.
All right, great. That's all our questions for our Q&A. Thank you so much, Dr. Fott, for presenting this webinar. We really appreciate it. And thank you all for joining us for this free event hosted by WePassed. This webinar will be available on our YouTube channel for the next 7 days. So if you need to review this presentation, be sure to check it out there. And this and many other recorded webinars are always available to WePass subscribers 24 hours a day, 7 days a week. So register through wepass.com to become a subscriber. And for up-to-date information about upcoming webinars, be sure to follow WePass on Facebook, Twitter, and LinkedIn. And if you have a moment, help us improve future webinars by taking this short survey. All right, thank you, and have a good night.